So we are at 5:05, so let's go. So this is the 9th consecutive AB1400 CalCare office hours. Office hours is about the bill that was introduced into the Assembly in February called AB1400, or the Guaranteed Healthcare for All Act of California, which would put into place the main structure for a single payer system in California. We'll talk about what that means. Office hours themselves are a chance for people to talk about that bill and learn more about it and share what they know and ask questions about what they don't know. And we are doing that every Sunday. We are also streaming right now on Facebook Live. This event is a co-production of Healthcare for All Los Angeles, a activist group that is dedicated to doing single payer and guaranteed healthcare in California, and also Physicians for National Health Program Southern California chapter. PNHP works towards universal healthcare along single payer lines nationally and in individual states. So that is what we are about. We usually start with a little intro to the bill. And just so you know also who your hosts are, I'm Dr. Ron Birnbaum, a physician in Los Angeles, and I'm going to turn it over to our other regular co-host, Jeanna Harris, RN, to do both our intro and a little special thing this week.
Awesome, thank you. And I am back after traveling. I just got back from Costa Rica because I had a utter meltdown. I was like, I gotta get out of here. I can't take it anymore. And I'll talk a little bit about Costa Rica because, like I told Ron, is that I noticed something about myself. Every country I go to, I start asking, what's your healthcare system like? Anyway, so let's talk about CalCare. Like he said, my name's Jeanna Harris. I'm a nurse. I recently got my public health nurse certification, so I have my PHN. So I am certified to talk about this now. Yay! Anyway, I digress. I feel like that's just a $300 certification that I get from the Board of Registered Nursing. Yay! Go broke getting certified. That's one thing. And the docs on the call, I know you guys know that pain very well. You go broke trying to get your certifications. Okay, so I want to share my screen because I want to share with you guys these 7 basic principles of CalCare. If I could get the right screen going, give me 2 seconds here. Hold on. I had it up. I had this all ready to go like I usually do, but for some reason it's not allowing me to. There it is. Okay. All right. So thank you, CNA, for providing a lovely toolkit. Also, Healthcare for All Los Angeles, we have created a lovely toolkit with graphics from Bronwyn Major, which you see right here behind me. So if you like these graphics, you let us know. We'll make sure you get them so that you can put them behind you too. So anyway, this is CalCare 7 basic principles. CalCare, or AB 1400, is a California Guaranteed Healthcare for All Act or bill. It is currently in the Assembly. I'm going to say, we're going to call it marinating. It is getting some nice, good seasoning because we don't cook bland food around here. We're going to make something very comprehensive and delicious for you. So it is a guaranteed healthcare as a human right in the state of California by providing comprehensive, high quality healthcare to you, just like Medicare for All would do nationally. Like I said, it's marinating. It's going to be delicious. It's not going to be bland. We're putting time and effort into this. It provides universal coverage because we believe everybody should be in and nobody out, regardless of your race, your sex, your gender, your country of origin, your disability status, immigration status, marital status, income. You get the care that you need. It should not be tied to your employment status, whether you're rich or you're poor. This is what I like to call a health equity bill. It's going to level the playing field. Just because you live in Westwood, you should not be able to get top premium care, but the people in Compton or in Southgate or someplace of lower income get lesser quality care just because of where we live or where we work or anything like that. That's just not good. So I like to call this health equity bill. It is a single public program that's publicly funded through progressive taxation. And that basically means if you make a little, you get taxed a little. If you make a lot, you get taxed a little bit more because, well, you have more excessive income like that. And so that's a progressive taxation. And it's to cover the necessary care in California, eliminating billions in bloat and waste, which is what I like to call the healthcare, system spaghetti. Imagine your healthcare system right now is a big bowl of spaghetti. It might look good, it might smell okay, but it's really kind of convoluted, it doesn't make any sense. That's kind of how the system is right now. And every single person has to pull apart all this disarray. That is your current healthcare system. And that's how a lot of money gets wasted. So we're trying to basically put everything a little bit cleaner and straighter lines. So things are straight from provider to payer, or, with the payer being the state, and make it a lot more simple so you don't get lost in that spaghetti bowl. It's going to provide full comprehensive benefits, including medical, dental, hearing, vision, mental health, very important, prescription drugs, long-term care, very important, and so much more. And the decisions are going to be about what care you receive should be between you and your doctors, not the insurance companies. The insurance company should not be able to step in and say, well, yeah, I know your doctor wants you to have treatment for your cancer at City of Hope because they're a #1 cancer center, but that's a top tier on the rate. So we're going to send you over to this hospital first. They should not be able to do that. If the doctor says City of Hope, you should go to City of Hope, point blank, period. And now, so then speaking of doctors, you get the freedom to choose your care provider. So some of us, a lot of times when we talk single payer healthcare, one of the first things people want to say is, well, I like my insurance, but they think their insurance is their doctor, and it's not the same thing. Your insurance may, your provider may, take your insurance, and that is how you see your doctor, but your doctor is not tied to your insurance. So under a single payer program, you will have the open network to be able to choose whatever doctor you choose. And it won't be tied to, oh, is this doctor in network? That's the first question a lot of us have to ask. It's like, well, is this doctor in network? Is this hospital in network? You're going to have the freedom to choose your care provider. So if you have a great doctor, great, keep them. If you don't like your doctor, go away and get another one. And then on top of that, it's free at the point of service. So no more, okay, welcome to your doctor's office, your copay is $25. No more of that. That goes away. You show them your CalCare card, they give you a nice smile and tell them to, have a seat, your doctor will see you in a few minutes. It's a just transition. So it's funding and programs to protect and support any displaced workers in the insurance industry like myself. Just transition means, yes, the insurance companies are going to act out. They're going to be like toddlers that we just took their favorite piece of candy away from them because, well, we're financing their candy by the billions. And so they're going to act out. They're going to be very harsh. They're going to try to do a lot of radical things that are unnecessary. But in this bill, written in this bill, is a just transition for people who need to be relocated to different jobs, who need to have, who have the skill set to go into a different setting. So if I'm working for an insurance company, maybe I can take my skill set, which I easily could, and take it to the hospital, take it somewhere else, and have a little bit of financial cushion and support to do that, have a prioritization in hiring to be able to do that. And that's kind of what the just transition is about. So while that is going to be a legit concern, just know that written in AB 1400 is this just transition. And then lastly, we're doing patient care based on patient need. If you do not need it, great. Okay, you don't need it, but if you need it, you should be able to get it without having to go through this hoop and that hoop and that hoop and that hoop and hope to God that you're still alive by the time you get to the hoop that you actually get your treatment. So patient care based on patient need, decided by your doctor, not decided by whether or not your insurance company wants to pay that rate that they have to pay for you to get that treatment. And ladies and gentlemen, that is the 7 basic principles of CalCare. This bill is very, very long, but this made it very, very simple. There you go.
No, that's fantastic. One thing and welcome everybody who's joined us, both in on Facebook and here. And so thank you for that. And you know, most of our time we spend on office hours with questions, which we either get from the comment or from the Facebook. But we often, one of our hosts, and this time Jeanna, also want to give like a little special something before we launch into general questions. So Jeanna, did you just go on a sunny vacation?
I did, and I am rather toasty. If you knew my color when I left here to the color I am now when I came back, it was unabashed sun, and I loved it. So like I said in the beginning, I went on vacation. I had to get out of this country. I did. I had to get out of here. And after being vaccinated, I've been vaccinated, 3-4 months now, looking at how everything's looking good. I finally put on my N95 with a very secure seal, and I got my tushy on an airplane. I handed it to Costa Rica, and I'm proud of it. So, you know, I did go to Costa Rica, and just to say, to get into Costa Rica, you have to have a negative COVID test. You have to, also purchase travel insurance. They are not going to support you if you come to their country with COVID or get COVID while you're there. So you have to get travel insurance enough to cover you for 2 weeks, including hotel and hospital stay, which equaled a total of $50 for me for 5 days. So it wasn't terrible. But since we are talking about, you know, coverage and things like that, if you are traveling, that is something that they have asked, and you have to get a health pass from their Ministry of Health. And you get scanned in coming into that country with your health pass. Actually, you can't even board your flight leaving LA to get to Costa Rica without having your QR code with your completed health pass on there. So that's just getting in there. But what I wanted to talk about is that to get out, I also had to have a negative COVID test. And the resort I stayed on, because yes, I did do a bougie vacation. The resort I stayed on did offer free antigen and PCR testing because you pay so much money at that damn resort. And so I talked to one of the nurses who was doing the testing. And of course, I'm in a foreign country. So I'm like, what's your healthcare system like? What is it really like? Because I've noticed as Americans, we kind of live in this bubble of thinking everything is fantastic here. Like we have the top tier, the best, but we know, especially if you're joining us here today, you know that might not be true. Costa Rica has been very chill country. They live the Pura Vida lifestyle, which is fantastic. And they're so off the radar, they don't even have a military. Now, I'm going to tell you, I kind of like that. I like the fact that your country is so chill that you're not starting any crap with your neighboring countries. You haven't started crap with America or any of the Americas. And you don't even need a military because you guys are just chilling. And I kind of like that. So maybe we should all just take our happy selves to Costa Rica. Yes, care not bombs. There we go. So a couple of things when I got back, I really started thinking about the Costa Rican healthcare system. And I was like, well, you know, I wanted to know more about it. I kind of knew it was universal, but I wanted to get a little deeper into it. So just really quick, they do have a universal, I have notes. So if I'm looking down, I'm reading notes. So they do have a universal system with private options. So you know how here we have a private system and they want us to go for a public option. It's really the reverse there. They have a public system and you can buy up into a private option if you so choose to. So it's kind of the opposite of what they're pitching to us here in the US. So that's a good talking point. Just keep that in mind. I'm not just talking about my vacay here. I'm actually really correlating it because a lot of the moderate to right politicians are like, oh, but we support a public option. And I'm like, well, no, public option should be the majority and it should be a private option if you so choose and want to go get your Brazilian butt lift. It's not my CalCare office hours if I don't mention the Brazilian butt lift. So then you have private hospitals. And they tend to want payment up front because they're private and they can do that. But then you have the public system that's offered free to all Costa Rican citizens. It is actually called don't judge my Spanish accent here. It's called the Caja Costarricense de Seguro Social, or just Caja for short. And it's basically that's what their public system is called. It is free at point of service, just like we said CalCare would be. most people, and this is mainly going off of, if we legitimately expat the US and go to Costa Rica, but on average, citizens are paying between 7 to 11% of their income on this system. And that is a kind of a progressive taxation, with the 11% being the highest. And that may sound, for those of you who don't know how much you're already paying to the healthcare system right now, that may sound like, oh my God, I don't want that. I don't want to pay that much. That's crazy. But you already are. Because for me, and I think I've mentioned this in a previous office hours, I kind of roughly calculated how much I'm paying with my private insurance through my employer, which is about 6%-ish. It could be more, because depending on how much I utilize my insurance, I'm paying 6% on top of still having to pay Medicare taxes, Social Security taxes, and everything. So I'm still paying either equal, if not more, than what I would be paying in Costa Rica with the universal healthcare system. So I'm just putting that out there to give a comparison, because I know just saying 7 to 11% with no context makes it seem like, well, I don't want to do that. But you already kind of are. And if you could, I would encourage you to see how much are you really paying with your private insurance, and then adding the Medicare taxes and the Social Security taxes and the state, Medicaid taxes all on top of that. Medical tourism from the US is increasing to Costa Rica because our health system is failing us. And so a lot of the older, like retired folk who are still able-bodied they're seeing the uptick in the last 10 years of them going down to Costa Rica to get care, because even paying privately, it's so much cheaper. I saw some numbers, for example, dental implants. I have a couple missing teeth in the back, and they're going to stay missing because I am not paying that much for dental implants. But if you go down to Costa Rica, the dental implant's like $1,000. And I think here an implant out of pocket's like $5 or $6 grand. So go on a Costa Rica vacation and still get a dental implant and still come out cheaper than what you would pay if you just went to your local dentist here. And that's just absolutely ridiculous. And so also the generic drugs are typically free. They actually manufacture drugs right there in Costa Rica. So go figure that. And then on top of that, they have one of the top 20 best public healthcare systems in the world, according to the UN, and the absolute best in Latin America, even beating out Cuba. So, Cuba's, I guess, do they consider that part of Latin America? I do. They're doing something right down in Costa Rica. And then I don't have the statistics totally, because like I said, my research was limited on this, but their quality of care keeps increasing. They keep doing trainings, they keep improving their healthcare system, but the cost is not increasing with it. So here we're being told that every year our cost is growing exponentially, which means the cost of healthcare has to grow exponentially. But somehow Costa Rica, with a healthcare system that actually was better than the US in the year 2000 by when the WHO did healthcare rankings, and I know that was 21 years ago, but I have a feeling that it's probably still better than ours now. Their costs have not increased as high as ours have. So what's up with that? And I'll just leave it at that. That is my little Costa Rican shout out to their healthcare system.
Wait, I have a question for you. Did you go into a pharmacy at all while you were down there?
No, I didn't go into a pharmacy. I mean, I did. They did have like a little medical center, like kind of attached to the resort. Where they had the basic stuff because, friends and hangovers need, a leave or whatever it was called. And it was like super cheap, or actually probably upcharge compared to what I would have paid if I would have been like in a local town. But, I didn't actually get to go into an actual pharmacy. I do know that they do not have the access to the vaccines like we do. And that is truly unfortunate because tourism is upticking there. So I am a little concerned. Because people, Americans, we're really tired, ready to break free and get buck wild. And with other countries, and I'll say this also as my public health, kind of PSA, keep that in mind as we're traveling globally. We may be able to get into these countries, and yes, you may need a negative COVID test, but we know COVID test being negative, you could have a false negative. Your viral load cannot be high enough to test positive when you test. There's a couple of things that could give you a false positive or false negative, and you still be carrying positive. So you should still take precautions. Keep those people in mind in the countries that you're traveling to, especially these island nations. And like I said, remember your privilege. We have had a gross supply of vaccine here, almost hoarding it. And honestly, wasting in other countries are barely trickling in their first doses. So just keep that in mind as we travel. We do not want to be the reasons why an outbreak happens like in Tulum and Cancun right now. They're seeing a large explosion, and I could probably say it's due to American tourism. I will confidently say it's due to American tourism.
So one thing that your story also brings up is related to AB 1400 is how does travel in and out of California affected by this? So there's a number of different ways that question can come up. Like, let's say you're just traveling, visiting your mother-in-law in Toledo, Ohio or something. But so you're not in California. What does the bill say about getting healthcare if you happen to, like twist your ankle and need to go to the emergency room in Toledo? And so it's been a while actually since I looked at the emergency provisions, but it does anticipate the contracting or doing some contracting with out-of-state providers for people. It right now though says that less contracted though won't pay for somebody who's out of state, and I'm not sure what it said about international travel. I can't remember because that's something I haven't looked at in a long time.
I think that when it mentioned international travel, I think it went back to the board to determine how the limits of that. I can't remember what page it was on, but I remember seeing it, and I believe it did reference. It was one of those, and the board to determine, how it does that. But I mean, even now, a lot of like with Part C Medicare, and I speak on that because it's because I know I've had patients that have been in Mexico who get sick and are actually covered for a limited period of time with the health plan. Like you get 2 weeks, and if you don't get better in 2 weeks, then you're just game over. And then also I've had patients where other plans did not cover, specifically one, I remember a story with LA Care. And like I said, this is dealing with the current Part C Medicare, not AB 1400, where a family had called and asked, would they be covered? And they were told no. And they were paying thousands of dollars down for their loved one in Mexico who got COVID, who was on a ventilator, and it was actually cheaper. It was cheaper. They found a way to provide medical transport with COVID to fly them back here to LA to get treated so that they were not having to pay so much in Mexico. So it is very tricky, but I do think international coverage would be something that would have to be further discussed when the board and everything is formed. And with you bringing that up, I kind of want to go back to emphasizing what the bill is and what it's not. The bill is a roadmap, but it does not have every nuanced question asked or answered in this one bill. It basically allows us to start the exploration. And something that we have never been able to do. And so I know that like everyone has these questions, questions about this, questions about that. And, to be honest, I'm like, well, I don't have the direct answer. The bill does not answer this directly. But, that is a question that once we start this exploration, we will have to, answer. We will have to answer about international travel. We will, and it does state that, you will be covered if you travel out of state on, visiting or on vacation or something like that. But if you move out of state, of course, AB 1400 CalCare will not follow you if you decide to move to New York. But if you decide to go visit New York and you twist your ankle because you saw a New York City rat, which they scare the hell out of me too, you will have some coverage there. So, I just wanted to share that, but I do want to, continue to emphasize that this bill allows us to build the actual system, not give us the system in its totality in this one bill.
That's right. It does. It has some things that it describes must happen, and then certainly allows other things to happen. It does. So Dr. Bill mentioned that AB 1400 is fashioned after HR 1384, a federal bill that covered all services out of state or international on an emergency basis. AB 1400 acknowledges that there are some people who worked in California, and then as a result of that work, retired, but before Medicare kicked in, because Medicare kicks in for most people around 65, and that it would still, that people whose work got them insurance through that way, mostly through in the public sector, working in the public sector, that if they retired out of state, that they would still, that CalCare would still work to cover them, so they're not forced to retire in California as the only place they could live. The other question is, what about people coming into the state? What about, sometimes people ask, will there be a whole bunch of medical tourism, or will this make a lot of people want to move into California? And what do you think, Bill? What Dr. Bill is gesticulating? What do you know, and what do you think?
Yeah, actually, it was a former chair of the California Democratic Party who coined the phrase that it would make California a healthcare sanctuary state, which would be absolutely 100% fine with me and most of us if people moved here for healthcare, because it would just, expand and grow the economy and the entire infrastructure, not just of healthcare, obviously, but for education and renewable energy and housing, affordable housing that we need in California. So yeah, bring us your tired, your bored, your humble masses for healthcare. Come on down and let's do this thing.
Just to add to that as well, number one, increased population, we get our damn congressional seat back. So that's a good argument for our establishment Democrats who are all about our seats and winning elections. And more population means we get our congressional seat back. And then also, people, when they say that, they're thinking Skid Row. They're thinking negatively. They're thinking we're going to get a bunch of poor people who are just going to mooch off the system. They're not thinking of having productive people come and join our society, and that's just a really dark and negative way of thinking. They're basically coming from the point of, I don't want someone coming to mooch off my system. And I'm like, well, likely if they can afford to get here, number one, let me tell you, having moved here, it is not cheap. And so someone who's already struggling in a state, they're not going to just pick up and move to a more expensive state. Getting here alone takes a small fortune. So I'm not too worried about people coming who will not be contributing or paying taxes and things like that, because it takes a small damn fortune to get here. And so, I just want to say that because I've heard that similar conversation, but they're coming from the standpoint of immigrant. They're basically talking about our immigrants from the South, saying that we don't want to pay for that. And this is, like I said, very right wing. This is the mod conversation. And they're also talking about people like, poor people, saying, I don't want them to come. But like Dr. Bill says, send me your poor, send me your injured, your huddled masses, because once we make them well, they become productive members of society and loyal Californians. So we should not be looking at this from a negative standpoint by seeing our population increase. Even if you come and you bring your mother with you who is sick, well, guess what? We're going to make her well. We're going to make her happy, and she'll be able to do something, contributing, if not just contributing her knowledge to the next generation. So we got to come from this with a little bit of compassion and empathy. That's what I wish my elected officials would do a little bit more of. But yeah, I see a hand raised.
I just wanted to say I so love what you just said, Jeanna. And we already have, I think, the country's largest unhoused population. So CalCare is, going to greatly contribute to that, to the solution for that issue, right? It's going to give the medical and the mental health care. And, Dr. Birnbaum, if you want to expand more on that, I remember Dr. Wynn saying, he's in the emergency room and people come into the emergency room and there's no way to follow up if they're getting the follow-up care. But with CalCare, that changes. You talk about wraparound services for our unhoused. Well, CalCare is huge wraparound services for medical and mental health care. And so we already have the largest unhoused population. So, you know, whatever, even if we have some more, we're already leading the way in that. But, you know, back in the 1950s, California had the best public school systems, and businesses located in California because of the school systems, and the people came. So I think that CalCare would be, you know, a business attraction in the same way that our public schools were at that time. And oh, I see Chris Shimizu nodding her head. She's a businesswoman. She owns her own business. And so I think that's another positive thing. It would attract businesses. It would add to our GDP. And then also, Jeanna, to your point, you know, it takes a lot to move anywhere. So, you know, if you own a home and you have a business and your kids are in school, it's going to be a lot of thinking before you just pack up and move to another state. So like you, I'm not worried about it. And I see it as a positive.
And actually, I'm interested to hear, Chris, what you think about that. But I'll make one more point that's related to like work and business and this thing. Let's say, you know, most people, or still the biggest single source of, maybe not by dollars, but by how people are covered is in the United States is through employment, somebody's employment. And that's a terrible system, because what if you lose your job? Or what if you, or what if you just want to change jobs? Or what if your employer just decides not to cover you anymore, or changes the amount you have to pay, or changes the plan to one that doesn't allow you to go to see the doctor who is taking care of you. There's the slew of problems related to employment-based health insurance is large. But let's say you were in another state and you wanted to start a small business, but you were going to lose you'd have to leave your job to do that. And then you'd lose your healthcare, and maybe that's your family's healthcare too. Maybe you decide just not to do that, start that small business. Or maybe you'd move to California and say, you know what, there, my family will still have healthcare while we start this small business. So, but I don't know, what do you think, Chris, about like, as a business?
Yeah, actually, I was thinking along the same lines, but kind of coming in from the other direction, like that as far as the current, you know, businesses that are already established in California, what you have is some serious, lots of little Davids and some big Goliaths. You have conglomerates that are controlling industries, that are deciding, just like, for example, in the corrugated board box industry, there's like a handful of companies suddenly decide, we want more money. We're going to raise the prices. And all of us in the entire, I'm in packaging, in the entire supply chain, what do we have to do? We say, yes, okay, prices are going up. That's the way it is now. And you know, so then you have, when you're competing with, you know, the real big guys like Uline, which would be like similar to like Walmart, or, you know, it's hard. It's really, really hard. And so being able to have more employees, and being able to have employees who are excited to be there with you, they're not, it's not about, you know, just trying to keep their health care and stuff. I think this is going to really impact the economy. It's really going to bring a lot of more energy. It's going to, and it's going to bring a lot more creativity and happiness, and therefore money. That's just the way I think it works, because it's worked for me in my business. It's just bringing the happiness, and the money seems to follow.
And I just want to add to what you were saying, Chris, because the California Chamber of Commerce, they've already put out their hit piece on this, saying this is a job killer bill. And I bring that up because that hit piece is going to come back out when this bill resurfaces. We know that the people in the assembly have already saw that hit piece, and that is what they're also using as a reason to not support this. But it may be a job killer, or actually it's not even a job killer. It's more, like I said, taking the favorite piece of candy from the toddler, and the toddler being the big insurance companies like United Healthcare, like, you know, Anthem and Blue Shield and all those places. And so that's when they say it's a job killer. It's a job killer for the Fortune 7, Fortune 10 companies who will just out of reaction and out of throwing a fit lay people off, even if they don't financially need to, because they're just not getting their way. But this is a job creator for the small business, because that's one thing that small businesses can't afford is health care for their employees. And so I'll just use a prime example. When I was a dialysis nurse, I had to do a lot of physical labor, and opening boxes with our supplies was one of them. And one time I was ripping stuff apart, trying to hurry up and get to a stat case. And I actually cut myself on a box, like really deeply. And so let's put that situation, and, you know, I'm kind of like, I got a boo-boo, you know, and I'm already in the hospital. So I'm just grabbing supplies off the shelf and, you know, bandaging myself up, but I'm a nurse. So if you had an employee do that as a small business owner, and let's say they didn't want to say anything because maybe they don't have insurance, or maybe they're using the marketplace with high deductibles, and going to the urgent care wouldn't even be worth it because their deductible's so high. So maybe they just put some stuff on it and keep going, but it gets infected. Mm-hmm. And still, maybe they keep trying to fix it at home, and the infection keeps getting worse and getting worse. And now they're going to go see someone like Dr. Bill in the emergency room, who's going to tell them that you have osteomyelitis and that you need 6 weeks of IV antibiotics, and now you can't work. And so that one thing right there, that tear, that cut that they couldn't afford to go and just get treated, now is costing you a lot of money, because now you're down an employee, and it's going to be costing the system a lot of money, because now they might apply for disability benefits, because now they're going to be out 6+ weeks. And so that's what I really want people to understand, why this current system doesn't work, and why something like AB1400, knowing that if AB1400 was in place, your employee comes to you as a small business owner and says, you know what, Chris or Miss Shimizu, I got a really nasty cut here. It's a boo-boo, and I think I need to go get it, you know, looked at. It's pretty deep. And you're like, okay, here's the rest of the day off. Let me know what they say. They put them on some antibiotics, they package it up, and guess what? They're back to work in a couple of days. End of story. Done. No major bills, nothing. And so, you know, and then they're back to work instead of being off work 6 weeks, and that hurts the GDP. So the current system is actually hurting the GDP and our financial system than having this in place. And for a small business owner, that one employee could have meant everything.
I want to try a slightly different scenario where the business owner isn't as nice as I am, and doesn't take the time to say, you know, oh, I noticed you've been injured, and you need to take care of that. And, you know, that is often not the scenario. However, if we had single payer, the person, you know, would know, even if they had to quit their job to take care of themselves, they'd still have health care. And that's one reason people just don't quit their jobs and suffer, is they think, oh, I'll be worse off if I give up this horrible insurance that I have. So.
Yes, thank you, Chris, for that. That does bring up a very good point as well. And then, yes, Dr. Bill, just to add, you know, in Canada, business owners don't have to worry about the healthcare. Like when you go to a foreign country and you ask someone, how much do you pay for healthcare? They give you a weird look. Like, what do you mean? Like, how much do I like to pay to go to the doctor? What do you mean? But I see a hand raised.
We actually, there's one
we have a
question before, which was Paul.
Oh, Paul, sorry about that. Love you, Paul. I didn't skip you on that.
And Betty would be next.
Hand up.
Sorry.
Anyway, no worries.
It was in the chat.
Yes, my question is I noticed that in my neighborhood, which is the West Side, Santa Monica, Venice, there's a huge influx of homeless people living on the beaches. Representative Bonin opened up a lot of places, one of them being State Beach, which is Los Angeles County. He opened up parking lots. There's a bit of fires being reported on in my neighborhood done by homeless people, at least they're being blamed. There's vandalism and petty theft and so forth. And in some cases, some assaults. A person I was with got a rock thrown at her, things like that. And this is mental illness, obviously, and this would fall in the preview of CalCare because mental illness would be treated. Can you elaborate on that and how that would be implemented with the homeless crisis we're having?
Ron, do you want to take that, or I can start it off? And
go ahead and start it off. I have lots of thoughts. Go ahead. Go ahead.
So first and foremost, yes, you are correct that a lot of this is mental health. And we know that our mental health system is fundamentally completely just trash. And that process was started before I was born. But adding CalCare, and I'm just gonna be very brutally honest because mental health is a really kind of personal, close issue for me. If we initiated CalCare tomorrow, how do we get the homeless on board? Now we can, like, just the same way we register homeless voters, we can do it. And I don't think that's too much of a barrier. The problem is the system itself, getting them into not just coverage. CalCare is the coverage. You're going to be covered, meaning you can seek mental health care and not have to worry about paying for it. But the system, how you get that mental health care, the mental health providers, the way that you're treated. I know in psychiatry, for treating a homeless person, you need to follow up. That's one thing. That's one big reason why we're seeing a lot of just out of control is the follow-up. And a lot of psychiatry, Dr. Bill and Ron, please correct me, but from what I've experienced, when we get mental illness into the hospitals, the psychiatry teams are not necessarily there to start you on a treatment that you will continue to take and be on. They're there to treat the immediate crisis going on. And that really honing into, are you going to kill someone? Are you going to kill yourself? And if you say no to both of those questions, it's kind of like off with you. And because I've had psychiatrists tell me it's a liability for me to start a treatment plan on someone that I can't follow up with. And that's how they look at the homeless people because they don't have phones. How do I schedule an appointment? So, we're really going to have to look at that system specifically very deeply. But the one thing that is going to help take off a lot of that weight is the coverage. They're going to be covered, so we don't have to worry about paying for it. We just got to make sure we have a system in place for them to be successful. And unfortunately, the American healthcare system has just completely swept mental health under the rug because they looked at it more of a kind of like a bad thing to have a mental health issue, and they don't want to deal with it. So they never put a lot of effort into creating a good mental health system. And so I just want to be honest with that. And I'll let Ron go in more about AB1400, the bill, because like I said, getting them covered is a big chunk of the problem, but it's going to be how we cover them. How do we provide access to them? How do we get them, following up and in the system and things like that are going to be, to me, a challenge in itself that's separate of just the bill. But this is going to be a great lift and hopefully open the door and allow more of the mental health forum to continue to talk, because actually I think either on the board or the committee, there has to be a mental health specialist or psychiatrist that it's either appointed to the board or appointed to the committee. So there should be good mental health representation in CalCare. And then I will let Dr. Bill or Ron take it from there.
Well, go ahead, Bill. If you were putting some statistics up, which I think would be worth people hearing, and there were sort of stuff along the lines. And when we finish this riff, Betty, will be your question. But
Sure. Well, thanks. Yeah, Paul, it's a terrific question, and you can kind of approach it from a lot of angles. But actually, one of the best angles is what you put in the chat, which is that our dear old friend in California, the ex-governor, and then went out to be president of the United States, Ronald Reagan, actually closed long-term mental health facilities. So if you think of the disenfranchised, the people who were literally thrown on the street without health care in this state first here in California, and then across the country with California as a model, that's what happened. They were thrown on the street without health care. So, I mean, that was really a sentinel event that you could point a finger at and say, that's what it means when you cut off healthcare for people. They will end up on the street, dying early, becoming, a scourge on the earth. And that's what California has become now. 30, 40 years later, we've become a model for that, really. So, so once you look at that, then you say to yourself, okay, so how then does introducing universal health care, as Jeanna says, once we establish that we can pick up care for people who are unhoused, how does that improve the situation? Then you look at people with untreated mental health conditions and untreated alcohol and drug rehab treatment that needed. You're picking up a whole lot of people at that point that you can then treat and have likely successful outcomes where they can regain a foothold and become productive members of society once again. And I think that's a huge number. Now, I haven't seen those numbers are like on the order of I believe it's 25% of all the homeless who have untreated mental health conditions. Another 24% have untreated substance dependence issues that are untreated. But economists, and in particular healthcare economists, have factored in those numbers into their equations. The other one is medical debt. How many people are on the streets as a result of medical debt, which obviously would be no longer exists under this system. Nobody would have medical debt anymore. How many of those people then regain a position in society to where they're able to house themselves once again? And again, that's where economists they can put dollar and cents values on that and do so all the time, and even estimate the expansion of the economy, job stimulus, all that stuff that we were talking about earlier as a result, and savings still, because we've eliminated that spaghetti monster, like Jeanna is calling it now, to the huge amount of administrative waste and the fraud and abuse. So it's very significant. That problem, in my opinion, I think the problem of our parentally unhoused population is gone. I mean, I think it's, for all intents and purposes, it's eliminated once we have a single payer universal healthcare system. So that again, more reason to come to California. If you're unhoused, come to California. We'll get you treatment, healthcare treatment, get you back on your feet, be a productive part of our economy and our society.
And
rose-tinted glasses, I know.
No, but it's such an important question because homelessness is such a bad thing, and I'll put one more angle on it that I think is, it's not like unrelated to some of the things that you guys have already said, but just another one. So that unfortunately in California, we now have like homeless families with little kids, but most people in the history of homelessness in California have went from being housed to unhoused. Like they weren't born homeless. They were living somewhere and then they weren't. They're very often renters. And but not always, not entirely. But there's often some set of events that happen that lead people, that push people over the edge. And when you start to peel away at like those different kinds of events, then you see that they are often there's a healthcare part of the story. So there's a lot of different ways that could work out. Like you can have a health problem, then get bankrupted by it and then not be able to pay your rent, and then you're homeless. Or you can have, say, a mental health problem, then struggle at work, then lose your job, then really have bad oh, this is
Getting bombed.
yeah.
You're gonna have to throw them out.
Yeah, you got it. I'm sorry. I thought I was in control and I'm controlling it, but I forgot. I'm not in control. I can't throw them out.
No, that's
Me too.
Yeah, make another co-host just in case.
I did, but let me but it's
can make-
okay.
You can make me a co-host if you want, just in case it happens again.
Sure. That's a first for
Well, we
so-
are very public. We're very public.
All
Yeah,
things
that's
to bomb. I'm like, I can give you a lot of good meetings to go Zoom bomb right now. I was like, this
Yeah.
isn't one of them.
That means they're paying attention to us.
Yeah, they're seeing us places, huh?
wait.
That should be the testimony to mental illness, because you got the crazy clown that they showed over
I
there.
just made you a co-host. So but and I know we're about to get and that's all good. What to say is that there's like there's these like events that happen just before people become homeless, and I think they're really important for us to understand, and they often involve a health problem, a job problem, a family, like a interpersonal crisis, a mental health problem, and any combination of those in any sequence. And then what's really terrible is, one, people who may have had the ability to get like care for that, but then lose it at the same time that they need it the most. And in fact, that's a feature, not a bug of our system, right? Like we have a lot of insurers who love that, like you lose it when you need it the most, right? And so a negative feature. But the other piece of it is that we were talking about like the complex spaghetti of our healthcare system. But think about people who, at the worst like crises of their life, when they need the most help, is it easy to navigate a system? Is it straightforward how you get help? Or are there a bunch of hoops, like you have to see somebody and get into somewhere who then makes you a referral and it has to get approved and all this stuff? There's so many ways where the crisis point gets amplified by our current health system that I think would go away with the system. So I really believe that, Dr. Bill, you are spot on, that in addition to helping so many of the people who need help in our homeless and unhoused population, I think it has a tremendous potential for prevention of homelessness in so many ways. But that's Paul, thank you for getting us going down that road. I think it was Betty who had a question. Yeah.
Yes, I do. Full disclosure, I am co-chair of Healthcare for Los Angeles, but I do have a question because I was being, I was asked last minute to speak at an Our Revolution chapter meeting this past week. And I got a question from somebody. I think I answered it, but, I could have done a better job, I think. So I'm going to ask it of you guys. Especially because you're docs and you got a nurse there, what happens to the doctor's pay? Will they get paid enough, or will they go running away from California and out of the state to go get paid somewhere else? Because that was the question. And we will lose doctors and we will lose healthcare workers because they won't make enough money.
There's a lot of ways to answer this. I can, but maybe Dr. Bill and I can each take a crack at this. First I would say, well, a couple questions that are part of that, which is like, how would doctors be paid in CalCare, and how would the amount that they get paid be figured out? And when I say doctors, I probably should generalize the term to healthcare providers who can generate a bill in some way from the work that they do. So, for example, a physical therapist could do that, or a dentist could do that, or there are others. A nurse practitioner could do that, and many others. So the short of the how they be paid is first they would be in one of two general groupings. So people who practice sort of more independently, like say just a family doctor who owns her own practice, and the general way that she would be paid is through fee-for-service, kind of like traditional Medicare, that the way that Medicare pays people. And I'm going to circle back to Medicare because that's an important part of this story about doctor pay. But the other big way that CalCare would pay providers in general is if there are what are called institutional providers. So big things like a hospital or a really big clinic. And providers who work at a place like that, while they potentially could be paid fee-for-service, they mostly would be paid salary in those places. So that's sort of the how. And then there's a little more on the how much. The rates, particularly on the fee-for-service side, would be negotiated. And the bill talks a little bit about how where those negotiations start. They start with Medicare rates. And then how they get done through a bargaining process of the CalCare board, which is the people sort of appointed to run the program, and they'll have all kinds of staff. And then doctors are able to essentially collectively bargain, or have people who are representatives bargain on their behalf, primarily, I think, on the behalf of a specialty type. So then that's the how. But then the question is, would it be up or down? And that, I think, there's a few more pieces I want to share on that front. So one is, if you look at the history of Medicare in the United States, a program that has a lot of political will behind it because there are a lot of people in it and who are politically active, that when there have been efforts to limit the reimbursement in a way that sort of would seem to harm access, that people wouldn't be able to that doctors would stop taking Medicare, a bunch of people get really, really mad and they make it not happen. So in other words, when you put everybody in, there's motivation to make sure things like that don't happen. In our current system, poor people often suffer because they don't have that kind of, they don't have the same kind of political heft to make sure that their providers are not sort of blown off. So that's one thing. And the last thing I'll say, I'm sure Dr. Bill will have some perspectives on this, is that in other countries, it is probably true that when you look country to country, that American physicians tend to make more. And so if you think of single payer as a system that might be more like some other countries, like, for example, Canada's, physicians do pretty well in Canada. There's probably in a lot of countries a relative better reimbursement for people who do primary care and more people who do primary care. Well, maybe a little less for people who do specialty care. But the last thing I wanted to say on that, and that may be a good idea because we would encourage more people to do primary care, we'd shift away from sickness care and stuff like that. But the last thing I'll say too is that we in the United States have been willing to spend way more than other countries on healthcare. And we might decide to pay people more than other people in other countries do. So I don't think other countries are a perfect example for this. Sorry, that was a long answer, but Bill, what do you think?
So here's the short answer.
Give a short answer.
Ron had the really long answer. I would just add to his really long answer that, first of all, it's not Medicare that doctors generally refuse. It's Medicaid or Medi-Cal in California. Medicare is a very high standard of reimbursement to doctors, just like it's a very high standard of quality of healthcare in general. That's why people like Medicare. They can't wait till they turn 65 to get it. So, you know, so it's a pretty good deal for doctors and for patients. The second thing I was going to mention is that in terms of what doctors get paid, it's not just the super specialists like Ron mentioned who are overpaid. It's especially most egregious among the surgical specialties, which are almost strictly fee for service. So they're almost never doing just and charging for an office visit or a bedside evaluation. They're charging, you know, by procedure over and over again, procedure, 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 procedure. They are grossly overpaid in this country, you know, in general, you know, and that's where you get into these bills, like how many operating room suites do they have set up? And I always joke, I want to make sure that they change their gloves in between operating suites, you know, between patients. So, you know, sorry, that medical joke there. Sorry, Dr. Wynn. I see Dr. Wynn joined us. Sorry, I had to make that kind of joke. But the final one I would say is kind of historical perspective, just to add to Ron's. And PNHP, Physicians for National Health Program, has really great data and historical data on this. Is the Canadian experience. When they started their Medicare, which is of course what they call healthcare in Canada, is Medicare. When they started, it was, you know, healthcare for everyone. When we got it for seniors, they got it for everyone. It was about at the same time, late 1960s. Doctors left Canada, right? In fact, there was this famous doctors' strike, and they had to import doctors from Britain to take care of patients. And then finally, the doctors stopped their strike. The Canadian doctors said, okay, we'll take care of patients. Well, you know, doctors did leave Canada initially, but now doctors are going to Canada to practice and have been. So the trend has been doctors have been leaving the United States to go practice in Canada because it's so much simpler and actually reimbursement is so much better. And, you know, especially in primary care, as we're talking about, you know, yes, if you're an ophthalmologist and it bothers you that you are only going to make $600,000 or $700,000 a year as an ophthalmologist, well, then maybe, you know, maybe you want to go practice in some other country at that point instead of here, because as Ron says, you know, and rightly so, we will want to adjust reimbursement so that we can emphasize primary and preventive care and actual bedside care and, you know, and office visits instead of all of that procedure care that has inflated care so much. And by the way, we woefully underpay pediatricians in this country, just like we woefully underpay teachers in this country, which tells you what values we have for our kids, number one. And we also woefully underpay mental health professionals of all kinds in this country. People think of psychiatrists as, you know, this really kind of grandiose job, but they are horribly underpaid in this country, especially for the amount of stress that it takes to be a good psychiatrist rather than just the guy who writes a prescription, you know. So this is the chance to do it right in terms of reimbursement to physicians. And the good news is, you know, I think, I don't know, the talks that I give with younger physicians coming up, the ones in training, they get that. They see that. They're not moving to Canada. They're getting in the fight for reform. And I think those of us in this room who are younger are going to see that change. And that gives me a lot of hope and joy to see that coming.
So it's actually, I'm glad you brought that up. And Ben, I just want to throw my 2 cents on this because I actually deal with the financials. So I am a go-between between, let's say, that surgeon who wants to do a procedure and negotiating that rate. And in my world, which is managed care, which is a big chunk of healthcare here in our country and in California, Medicare rate is basically the highest, like it's like the highest. The goal in our negotiations is not to hit Medicare. Okay, so we're going down from Medicare is like, we ain't going above it. Or we're not going to get to it. So we'll pay you 90% Medicare. We'll pay you 80% Medicare, 70% Medicare. And I was just on a operational call with a home health vendor. And, they were letting us know that, well, we would love to service certain areas, but we can't afford to pay the nurses. And that's because the rates are too low. And, and it was kind of, it's always that awkward conversation because I have no power of like increasing rates for people. I just have to hear it from both sides, like, we're not increasing. And then, well, we can't service you until you increase. So I'm just hearing this in both my ears. And so when it comes to physicians and care and their pay, we also have to consider that what I'm confidently sure they're going to use Medicare rate as kind of the standard in AB 1400. You may see that maybe pay won't change much at all, but we're going to have, like Dr. Bill was saying, a shock factor. And because of how the narrative is going to be driven, everyone's going to think that they're going to be living on Skid Row when AB 1400 passes because their pay is going to be cut so terribly. And as a nurse, I don't get to negotiate my rates. I don't get to do fee for service. There's no fee for putting you on a bedpan. There's no fee for holding your hand while you die. There's no fee for listening to you for 45 minutes because I became your psychiatrist. I don't get to do that. Sometimes I wish I could, but I can't. And so I will be my salary is going to be completely dependent upon the company I work for, the hospital I work for, however that works, because I don't have a billing system. There's no unless I go become a nurse practitioner or whatever, I'm stuck to whatever my company does. And so I just wanted to add that 2 cents in there because it's going to be a long road on that. I do expect a shock factor to happen. I do expect some temper tantrums to happen. But I do expect, like what Dr. Bill said, in the end, it'll all be okay because everyone's going to realize it's going to come back. And just like a lot of people were focusing on preventative patient-centered care because it is the most affordable. Keeping you out the hospital is the most affordable. I tell my higher ups who wanted to ask me about how to decrease readmission rates and how to keep people healthier and why are patients coming in with congestive heart failure left and right. And I simply go back, your PCPs aren't doing your job. You let them hit my door, you lost your game. You let them hit this parking lot, you lost the game because the minute they hit the parking lot, they're admitted. And then you lost the game. So I'm like, you want to focus on PCP, patient-centered preventative care, which happens completely outside the hospital. That all happens in the primary care office. And that means we're going to need more primary care doctors who have lesser patient panels who they can spend more than 10 minutes in the office with you, talking to you, educating you. And most importantly, and I'm going down a rabbit hole, but we are all going to be responsible for our healthcare. Okay. Under AB 1400, we are all taking a pledge that I am pledging to take to treat myself better. Because in treating myself better, I am going to make sure that this system has longevity. If we continue our current health mentality where, oh, I'm sick, I go to the doctor, I can do whatever the hell I want to my body, I can eat what I want, I can do what I want, and then I'll just get sick and I'll go to the doctor. And that's not the way. We need to treat ourselves better. We need to be healthier. And then if we get sick, go to the doctor, show your CalCare card, have a seat, 15 minutes later, here comes your doctor, and you get the medications you need, you get whatever you need, and you go home, you don't have a bill. That's going to be the beauty of it. But like I said, we need to treat ourselves better as well. And I went down that rabbit hole, but I just wanted to add a little bit of the financial negotiation side on that too, which honestly, Medicare rate is the creme de la creme of rates. So yes, if we can keep things at Medicare rate, people, especially in the managed care world, might actually be pretty happy. And Maureen, I know you have a question. Hi,
Well,
Maureen.
I just wanted to add, I'll add now to my answer. I did add to my answer something that you touched on, because when I was, regional for SB 562, I did have a doctor reach out to me later in the game, like kind of like when the bill was getting, was getting shelved, and he was kind of like in this, like, we need to get, he must have just heard about it. I don't know how that could happen, but just heard about it, whatever it was. And he told me that he owns like some like emergency, he's an emergency room doctor, but he also owns like some like urgent cares, you know? And he was saying that the billing and administration was eating up everything. It was like time, and I think over 15%. And it was just like, he was, you know, so I think that at this point, people don't realize this private system eats up the doctor's time and eats up the doctor's, you know, whatever income they have coming in by administration, you know, and that goes bye-bye. So just wanted to add that in. Thank you for answering that question in length. I'm glad now I'm more powered up with information if I get that question again.
But Maureen Cruise, saw you had
Hi there. Hi, everybody. I had a couple of comments and a question. And I came in late, so if I'm off base, just let me know right off the bat, okay? You were talking about, you know, primary care, and I'm imagining you covered one of the great benefits is that students can now choose, medical students can choose to do what they want and not feel like they're going to be deluged in medical debt when the payments are equalized a little bit better. And that I was looking for it, but I can't find it right now. But I was reading that, of course, we all know that other countries that have universal systems of some kind or national systems, they have far greater percentage of primary care than they do specialty and surgeons. And at the same time, they have better outcomes. And at the same time, they have, like, all boats rise with the tide. The other metrics that you're talking about, like health maintenance and areas like homelessness and areas of social concern, like food security, all those things, when you have a system that's laden with primary care, that tends to raise all of these other social determinants. So that kind of feeds into what Jeanna was saying as well. I did have one dispute, and Jeanna, there is always a fee for a Band-Aid, a bedpan. You just don't get it, baby. You are not going to get the money, honey. It goes straight to the hospital, which is why the California hospitals made $97 billion in profit last year during COVID. And their complaint was they lost 4% because the year before they made $101 billion in profit. And that's like 435 hospitals or something. I think, I don't know how many have closed since I saw that. But here's my question, and that is currently the Medicare rates for the different practices are set by a board. And my understanding is that that board is heavily weighted with surgeons and specialty practitioners. So I'm wondering how AB 1400, is there something in that? Like who's going to decide the board? Because right now the board makes a big difference. That's why pediatricians aren't paid well, is because that board doesn't have pediatricians on it. So that's my question is does anyone know how that's going to work?
I know a little bit about it. So first of all, the board you're referring to is called the RUC. And I always have to look up the RUC. But what in our current system, I'll try to clarify a little bit about that. There's a lot of the payment rates are set using fee-for-service methodology based on what Medicare does. So how is that determined? And then as Jeanna was saying, a lot of other things get determined based on that. So one is that they that there is this whole kind of concept, which is the relative RVU, relative value unit, that is like across different types of procedures or evaluations or something like that, will have like a set value of what that will get paid. And then what the RUC is doing is negotiating among themselves, and they are a board that the AMA is involved in, who's on the RUC, that has a mix of people who do primary care and specialties. And it's, yes, probably weighted too much towards specialties. And so they negotiate these things out, and then the specialty stuff tends to get higher relative value units for their procedural codes and their evaluation codes. Anybody who knows better than me can correct me. So that is a weird thing, which is that it's set right now, it involves Medicare, but involves the American Medical Association. So the bill, while it still looks at what Medicare is doing as kind of a starting point, it describes direct negotiations between the board and individual groups of specialties and individual institutions for negotiating. And in the case of institutions, that's negotiating what are called global budgets. So it is really different. And I don't know that it's entirely clear how that structure would affect those, the relative amount going to primary care versus specialties, but it's a really different method than we're using now.
Yeah, I have one other comment about the billing with HMOs, specifically Kaiser, because I noticed with my mother when she was, in her early 90s, and for myself, they have a very lazy actuary apparently, or a bad computer program or something, because I noticed everything, all the charges, whether it was physical therapy or staying in the hospital or going to the respiratory therapist, it worked out to be $1,000 an hour. If you went to physical therapy for 15 minutes, it was $250. This is what they charge. That's not what they got. My mom was in the hospital 37 hours. It was $37,000 that they wanted to bill. The Kaiser, they list what they charge, and then they list what actually gets paid to Medicare. So I noticed, and then my mom went to the respiratory therapist. Interestingly, and not a therapist, it was as a tech to give her a couple of, breathometer tests and such. So it's the same person in the same room with two different tests, right? Each one takes 7 minutes or something, 10 minutes. And so they bill for 2 separate sessions. They bill you for 2 separate 15. This is the kind of stuff that, bumps the bills up, which is insane. So my mom went in, I took her in, and it was one guy, one test, and then they gave her a second appointment back to back. And then she got another test, same guy, same room. We were out in 20 minutes, and the bill, as far as Kaiser was concerned, was $500, right? For 2 sessions with a respiratory tech. So along with the co-pays for 2 appointments, right? I mean, this is the kind of scamming that they do, along with the upcoding. I'm on no medications, and I don't really have any health problems. And if you looked at my record, you'd think, oh my God, she must be in the hospital, because every time you go in for something, it's on your record. And they always give you a prescription for something, even though you say, I'm not taking that, I'm not sick, I'm not, you don't fulfill the prescription, still on your record. And so this is a way they upcode and say, this person is really, she's got this problem, that problem, the other problem, when in fact, you don't. Maybe you went in once for something and it resolved, but it's on your record. So they get to tell Medicare that people are far sicker than they are. And Jeanna, I know you see this all the time, but I throw that in there because the $1,000 an hour really got me, because I started looking at it and I thought, wait a minute, it's always $1,000 an hour, no matter if it's physical therapy, respiratory tech, or being in the hospital. It's $1,000 an hour. So they have a lazy actuary or something, I don't know, who's not willing.
Yeah, so I just wanted to add to that. So, I mean, yes, the billing is insane. How they determine these costs, I don't know what science they're using. But I will say, when it comes to things being added, I have seen doctors get grilled, because, patient came in with, AFib, and I hear it all the time. Did you make sure you add the code for second hypercoagulable state? Did you make sure? Because that's how we get additional payment. because you have to add these codes. Dr. Nguyen's like, oh yeah, I know that one. You know that code by heart, don't you? Yeah, you do. And so, you know, and like I said, I don't know.
I just have to interrupt and ask, are there like 4,000 codes, 5,000, 10,000? How many codes? Like thousands?
I think more codes than the Chinese alphabet, I'll be honest. But you know, yeah, I think there are tons of codes, and there are programs that will help us with codes. A lot of the EMRs will already have a lot of the codes built in. So it's not like we have to like know them off the top of our head. I'm just being fully honest, you know, like write every single code. But, you know, sometimes it's like the way that hospitals and the insurance companies are getting right now because of these codes, insurance companies are getting extremely petty. So if code is, it's like the Dewey Decimal System, you know, you have, you know, code number 100 point blah, blah, blah. Well, if you don't bill correctly, and let's say Dr. Nguyen's tired, he's come, you know, it's been a heavy COVID day and he's still having a document. He's got to enter. Yeah, he's been going on. Yeah, so he's got to enter these codes. And let's say he forgot to put 0.02 and he put 0.07. And then that goes through the system. Then they send it off to insurance for claims. And let's say it was a $50,000, $60,000 thing. And guess what? That gets denied. And so now the hospital's going back through the denials process. Here comes that bloat that we're talking about that will be eliminated in AB 1400. Because now the hospital's fighting the insurance company claims process because their $50,000 claim was denied. And that's not something they're just getting ready to write off. They may write off a few thousand, but they're not letting 50K go, especially right now. So, you know, I just wanted to add that because it is really important. But Maureen, to go back to your question about the board and how it's formed in AB 1400, I just wanted to read that to you because I do have, it's kind of like one of those ticks where I'm just like, I'm not 100% okay with this, but I think that this is a bone that was thrown to the moderate side of our state and our party and our elected officials. So I just will read this because this is a direct quote from the bill that CalCare shall be governed by an executive board known as the CalCare board. We all knew that, consisting of 9 voting members who are residents of California. The CalCare board shall be an independent public entity not affiliated with any agency or department. So California Medical Association cannot have their fingers in this, or well, let me rephrase, should not have their fingers in this, just as much as CNA can't have their fingers in this, and that's kind of sad. But you know, either way it goes, I don't want California Medical Association on this. But like I said, you'll see why this gets on my nerves a little bit. Okay, so of the members of the board, 5 of these 9, so we're now over 50%, shall be appointed by the governor, so Gavin. 2 shall be appointed by the Senate Committee on Rules. So now we're at 7. And 2 shall be appointed by the Speaker of the Assembly. So now you see why there's something, the board. But anyway, I'm not going to let that, you know, rain on my parade at all. The Secretary of California Health and Human Services or the Secretary's designees shall serve as a non-voting ex officio member of the board. So the board will be determined by our elected officials. And we know who sits in these seats that I just named. And so from day one, having read that, I became a little bit like, oh boy, just like the Medicare, the RUC board for Medicare, we are a little vulnerable on this. But since we know this and everyone watching, you know this, that means that once we get CalCare up and running, I'm not going to let this be a showstopper. I'm not going to let this be a deal breaker for me. But I will say that to Gavin and to Anthony Rendon and to, you know, the other people who get to appoint to the board, you will have public pressure. We will watch you. Every single person that you think you're going to appoint, we will be looking at them. And if I see that they are tied to the California Medical Association or to someone who is not going to put this bill or the Californians in the best interest while they're helping us, or if I think they're going to be there to maybe not be so good and maybe block this bill from being formed or this, you know, the program. I think that we will be able to, you know, we will be able to help pick what's on this. Now, granted, there's also a committee that is formed. So A member of the board and also the ex officio shall serve for a 4-year term, except the initial appointment by the Senate Committee of Rules, which may be a term of 5 years. And the initial appointment by the Speaker of the Assembly shall be a term of 2 years. And they could be reappointed for another 4 years. So then they also can form, the appointing authority shall also consider the expertise of the members of the board and to attempt to make appointments so that the board's composition reflects a diversity of expertise in various aspects of healthcare and the diversity of the various regions of the state. Appointments to the board shall be made as follows. It has to be 2 healthcare professionals who practice medicine, 1 registered nurse, 1 public health professional, 1 mental health professional, 1 member with an institutional provider background, so big hospital system, AKA. 1 representative of a nonprofit organization that advocates for individuals who use healthcare in California, AKA Maureen Cruise. I just appointed you. And then 1 representative of a labor organization. So we could get a CNA or SEIU, one of those members could be appointed to this. And 1 member of the committee established by section 100611, who shall serve as on a rotating basis to be determined by the committee. So, you know, there should be diverse representation on these appointments, but like I said, you know, kind of where I want to go with that. And so I just say that we will have to watch closely, but the whole first point of this, before we can get that, we have to get AB 1400 passed. And one of the things that I don't understand why Governor Newsom is not jumping on board on this is because you literally get 50% stake on the people who get to determine this entire program. This whole bill is riddled with the board to determine, the board to determine, the board to determine. This bill literally says the board to determine, along with Health and Human Services and the Secretary of Treasury, if we can even move forward. Once we put all this work forth, if it's not sound, it can't move forward. And Governor Newsom gets a 50% stake in the people who get to make that decision. So I don't understand why he's not fully on board with this yet, but that is my saying. It's like, dude, this is literally your thing. Like, you get to control this. This is Gavin care. It's not CalCare, it's Gavin care. Stroking the ego a little bit on that one. I just want to sign it.
All you have to do is follow the money and you'll find out why he's not interested. And the Governor's Commission on Healthy California is an example of what can go wrong. We have 12 people. The governor appointed 8 people and only 3 are single payer advocates, possibly a 4th one, but 3 for sure out of the 8 that he appointed, and the others are opposition. Okay. And then of course the other 4 are opposition, and Galley is a public option fan. And then you have an ex officio group. I don't know how they got appointed. I don't know where I know who they are. They're all anti-single payer, but I don't know how they got appointed. So you're right to be concerned about that. And that the bill that established that Governor's Commission on Healthcare, Phil Ting Bill 1810, that was signed by Brown in June of 2018, that originally only had 5 members, and it ballooned to 12 appointees, then the Secretary of Health and Human Services, and then 5 ex officio. So it ballooned from 5 people to 18 people. So things can change. Things can change.
And let me say something, which is, so to steer us back to the bill, because that commission is sort of, it's related in a certain way, but it may or may not ever have anything to do with this particular bill. And that's, I guess, one of the questions about the commission. But I think that one thing that, you know, in picking up like some of the little strains of conversation that have gone on maybe the last 15 or 20 minutes, where we were talking about like codes and like the little bit sort of like minutia of how do hospitals get paid and how do people get paid. And that is, our current system is like, it's incredibly complex, right? When you get to how hospital people and doing stuff in hospitals get paid, it is incredibly complex. And one of the things that's both a source of savings and also simplification is the global budget's plan for paying hospitals and institutional providers in CalCare. That makes things a lot simpler, and there's just a lot fewer games. On the outpatient side, the people getting fee for service use codes and that kind of thing too, but it's still much simpler. And when you only have one insurance company, which is the state, and it's just sort of individual kind of straightforward transactions, is it impossible for there to be games or fraud? No, it's not impossible, but it's much simpler. And so when things are simpler, it's easier to follow the money. And the last thing is that it's an interesting conversation, because I think some people have, like Jeanna was saying, have looked at AB1400 and wondered, is this the very best way to run the system with a board of 9 people? I think there's a reasonable sets of discussions that people could have about that. But one thing you could say at least is, you know who's in charge and you know who to try to hold accountable in that system. In our current system, it's incredibly bewilderingly difficult to hold anybody accountable for stuff that happens, right? Like it doesn't very often, you can't often even figure out who's behind all the weird things that happen, or why was something denied, or it's like, so I'll just say that there's still a lot of work to do in this whole area, but I think I see, Maureen, you have your hand up, but there had been an Alberto Saavedra.
Oh, go ahead, Al. My question was a
while ago. So
I have to disappear for 3 minutes anyway. I have to disappear for 3 minutes anyway. I'll be right back.
Okay, come back and ask your question. But
hi everybody. I think that Dr. Bill answered my question in the chat room, but essentially years ago, I sold a computer system to United Health. And after I sold it to them, they told me they were going to use it to deny claims, to find problems with claims so they could deny them. They also told me they deny about 30% of all claims. And my question was, would that affect a doctor's pay if the claim is denied? And the answer was probably. Am I right, Dr. Bill?
Well, I think you're right, but it's complicated, and it's supposed to be this kind of interfaces with Dr. Wynn's comment in chat, which is that it's meant to be complicated. So, some doctors absolutely will impact, some not so much, so it depends. And that's why doctors in practice, have to refuse this kind of insurance or that kind of insurance, because they know that, if they take this one or that one, they will get refused, for things that they consider to be within the scope or usual and customary of the practice. So, but what I find really egregious about your comment, Al, is that these insurance companies admit to a figure like 30%. That's boldface. And I would want someone like Katie Porter to come out with her whiteboard and start, grilling them on these things and say, well, how did you arrive at that figure? You told this, I'm sure you were, making a guess of some kind, but look at these figures, just happens over and over again. And consistently that number is 30%. How can you possibly arrive at a 30% number in any other way except adjusting your information systems to produce that number? And that would be egregious. In my opinion, that would be some form of racketeering, perhaps. I don't know, but it sounds illegal to me. So, that's what they call redlining, right? And so, that shouldn't and can't be the case.
So, and I just want to add a different perspective. the doctors are put under a lot of extra stress based on this billing. So while you might not see in an immediate change in doctor pay, especially if they work for a big group or something, but if they're like have their own physician IPA or independent practice, their livelihood could be based on that billing. So if it's one doctor who maybe made a couple of mistakes, that doctor is going to be put on a performance improvement plan. That doctor's going to, you know, definitely be talked to, which adds extra stress to them because their whole purpose is to take care of the patient. But now they're stressed out, worried about the billing portion of it because they don't want to get written up. They don't want to get fired or have their contract pulled because they did not do the billing timely enough. I actually saw a doctor, which became a good friend, get fired because he was not doing his billing timely enough time after time. And granted, part of it was an attitude issue, but even after me, you know, trying to help him, like, hey, you know, I'll come to your house and like, let's just do your billing. You pay me in food. And you know, and let's just knock out your billing and get it caught up. Unfortunately, it was too late. But that's where we're at with it right now. Doctors can lose their job if they repeatedly do not do accurate billing or timely billing, because it's just hurting the bottom line too much. And yes, Jeanna and food. Okay, I know we're in the last 20 minutes, but Al, did that answer your question? Okay. So I wanted to go up to Richard. You had your hand up, but then you put it down. You took it down? Okay. Erica, you're up next.
Gee, Jeanna, now I know why you volunteer at the food bank. It's a theme.
Thing.
Oh.
You can pay. I can be bribed. I always say, you know, when people are like, you know, we worried about medical bribes, right? And I'm like, look, you can bribe me with food because there will be no evidence left. Don't bring me cutesy stuff or send me on trips. There's evidence with that, but just bring me food.
So this theme of complexity, right? It's intentionally complex. It's complex all the way around. It's complex on the patient's end when they go to an institutional provider. It's complex on the healthcare provider's end within the institution. It's complex on the independent healthcare provider. And we all know that it's, as Dr. Nguyen wrote, that it is intentionally complex because that is how you hide fraud and abuse. And so, Dr. Birnbaum, I'm wondering if you can take this. I'm finding myself, the word or the phrase, it's complicated. I hear that a lot in the activism world when I'm trying to talk to people, let's say about CalCare, and I get to a point and they'll be like, I was at a meeting yesterday and people were under the single payer activists were under the impression CalCare would go away with Kaiser would go away if we had CalCare. And I was explaining, no, just Kaiser insurance would go away. And they're like, well, it's complicated. And that's always the thing that shuts down the conversation. So going to using the bill AB1400, can you take that and put it like as a tool in my hands as an activist to be able to come back and say, no, actually, it's pretty simple.
Is what the thing about Kaiser and HMOs, or about, or what thing would you want to hear more simply? Clarifying the question. Your question is complicated.
Well, I think in general, people will be like, well, the whole thing is just, it's just complex. So like, we can't even like, it's just so complex that we should all just give up. Like, so it's just about single payer and the medical system. So not even specifically, I used Kaiser as a specific example, which I will get that as well in that specific round, but in general. Does that make sense?
Right. Well, so no, I do, which is that, and you could say like, is one of the downs, like, why are we having these office hours? Well, we're having office hours so we can have some conversations that aren't just 5 minutes long about some of these things, right? And maybe that's what some of the people who are saying it's complex are trying to say, which is that, like, okay, we'd have to get really into a lot more discussion than we're able to have right now. But complexity is still used to obfuscate. And I think this is a really important question, because as activists, we have to be able to have a short conversation with people too about what this is about, right? And it sort of goes like this. Right now, we have a really bad healthcare system that costs too much, that's really terribly unequal, and that has really bad results, including things like more people, like increasing, like the shortening lifespan, which we've never even seen in the country. And that's really bad. And if you're defending that, you're defending something really complex that's doing poorly. So there's a simple proposal up in front of the legislature to take all the money, put it in one pot, and give everybody the health care they need. And that's at its heart what AB 1400 is about. I don't want to like say, oh, there's no details, there's no impacts on some other, on this and that. There are, but that's what it's about. I'm not sure if that's what your question was about, though. Is it like because it's you could put the burden of complexity back on anybody who is sort of arguing against this system.
So
right?
Can I just ask, I think, Erica, I know kind of also where you're coming from. People want to know, basically, they want to see the beginning, middle, and end, just as much as these elected officials who keep saying there's no financing want us to produce a ledger of bills and ins and outs of financing for them, even though we know we can't do that. That's their excuse that they're hiding under. At the same time, even in the Chaburp review, it says that this is going to be an extensive undertaking that will take lots of time. So undoing the spaghetti monster is not easy. And it is not one conversation. Like Ron said, the reason why we're doing these office hours, because the easiest 5-second answer to what the question you were being asked is, it's complicated, just as much as my relationship status is complicated. It's a spaghetti monster all in itself. But one thing it is that no, I cannot tell you exactly what Kaiser is going to do. I cannot. Why? Because no one in the history of effing single payer has allowed me to go explore it. And so that is the reason why my relationship status is spaghetti monster, by the way. And so that is the reason why there's nobody that can give that direct answer. And that is what I'm telling people, is that the answer you're looking for comes with the passage of AB 1400, because I need the ability to take Starship Enterprise out on her maiden voyage so that I can see what the hell is out there in the solar system. Because at this point, we have never been granted access to explore this type of healthcare system in depth like that. We can do studies, we can look at global, what's happening in other countries, we can put together stuff. We have all of that. But if you really want to see how it's going to affect us, get AB 1400 passed so that we can go build this out. And then I can come back to you and say, boom, 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 boom. It's going to be done like boom, 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 boom. And this is what they're going to do. But that I can't do that because I can't get Starship Enterprise's engine started without this bill being seen. And yes, I did do the Trekkie thing and I just showed my nerd status. I am so sorry. But I just live well and prosper. So I just wanted to, Erica, because I've been asked that, and after thinking about it, having read the bill more than once, I don't have that direct answer. And I think that I realize that if I can't answer it, it's because we literally only have preliminary studies of comparisons and hypotheses, but we have not been able to really say that, okay, this is how it's going to affect you. Because we could, like Betty said, we could look at the VA system, we could look at this, but it's not going to apply to the people in the way that they can relate until I can say this. Because we brought up VA, we brought up Medicare, and it's still not clicking in the brains of the people just yet. And I see, Rich, you had a direct response that you wanted. So I'm just keeping track of time. I could go on about that, but I'm going to shut up.
I'm going to try to keep this brief, but this has always been my response to when people bring up that it's complicated thing about, and then the questions as to, well, what will happen with Kaiser and with things like that. And honestly, we have our theories, we have our feelings as to what would happen with insurance, et cetera, but do we know exactly what will happen? The answer is, there's no way of knowing, right, until things actually occur. I related to a story that I heard about recently, in that the local mall that I live next to, the Del Amo Mall, is recently, the Sears there closed down after, I think it was like 40 or 50 years of being there. And people attributed to the fact that that mall became this behemoth of a mall where they kept on adding on more space to it, adding on more things to it. And it became so complex and complicated to navigate. There's no way of figuring out where the Sears was. It's really hard to find it. And so Sears ended up losing a lot of business and ended up having to close down. And that's sort of my analogy to the system now, in that we have this behemoth that has been built upon with these extra additive parts, and insurance companies has become very complex, and there's no way to navigate it. It's hard to know where the money goes, where things flow, and etc. And so when people talk about Sears, they said, back 20 years ago or 30 years ago, there was a decision to be made that we would renovate and we'd add on to the mall. Instead, we should have knocked it down and rebuilt it. And that would have made something much more practical, something that we can navigate. And then all of the businesses would have thrived. And that's the analogy I make with AB 1400. It's time that we sort of break things down, rebuild it, make it practical, make it something that we all can navigate and we can understand the ins and outs of, rather than just keep on adding on to this behemoth and making it worse than where it is.
I just want to say thanks, guys. I know that was a kind of a weird question. It was big, but everybody's answer really helped, in what you wrote as well, Dr. Bill, in the chat. And I think I'm walking away with, also, I can say it can't get any more complicated than it already is now. So this is moving in a direction of simplifying it, but thank you very much.
I also like the fact that you related it to shopping, and I will use that because Del Amo Mall is a hot mess. It's like two different malls that have been strung together with high-end. It's like Del Amo Mall has its high-end store side, and then you have the normal people side, and Sears was on the normal people side. And what happened? The 1%, that high-end side got redone, and the normal people side, where Sears and JCPenney and all that stuff was, well, it still looks a little dilapidated. So that's another way of putting it. Like, look, they're always going to focus on that 1% if you don't make them focus on, you. But thank you for relating that to shopping. And then Maureen, I see you're back, so I will, you can come off mute.
Thank you so much. That is a great analogy, Dr. Nguyen. I guess one of my concerns is, it's probably because we're in a capitalist country, that, the health of the country is the GDP and the stock market, not how many people are on Skid Row and how many people are food insecure and how many people have lost a limb today. I'm really feeling like we need to move somehow to talk about what's happening to people and their lives, right? What's happening in the system now, and how that, to your health, to your well-being, to your morbidity, to your mortality. And that's what a healthcare system is supposed to be about. But because we have this insurance system, we're always talking about the money. It's always talking about the money. So I had actually a question for Rich. Rich, do you see in your practice, your ER, right? Your ER? No, what are you? Cardiology.
I'm in critical care.
Oh, critical care. Okay. So do you see, and I'll ask the same of all the doctors actually, do you see in your practice things that make you cringe because you can't give a person the care that they really deserve? Do you see your patients suffering and a person's health being affected negatively by the system as it is? And maybe we should start having doctors talk about that. If doctors do feel that, you're looking at the way in which your profession has been hijacked by a business plan. And I'm saying this, every time I see something, I just go crazy, like when the this, I think he was a 2-year-old, died between Drew and Kaiser, because Kaiser insisted that the child be transferred to Kaiser because he was a Kaiser patient, but he was in critical condition and he died on the way. And in the meantime, his mother was really upset about the fact that he was becoming worse and worse. So what did they do? They called security and hauled her out. So the humanity, we are missing the humanity in our system. We are missing the care, and we are missing the health. And I just would like to hear from the doctors if you feel this has been something significant. I know, Rich, you're more of a new doctor, and Ron, you're more of a middle doctor, and Dr. Bill, you've been around a while. So I'm kind of curious as to how you see things now, and if you in your time have seen a change, and in what happens to your patients, because we have to start talking about what the health system is about, your patients. So that's my question, and I'd like to hear from all three of you.
Well, so as the youngest or least experienced, I'll go first. I think absolutely we have these experiences, and we have them far too often. I think at one other meeting before, I'd mentioned that, I've been doing these sort of talks, sporadically for the last, I don't know, however long it's been. And it dawned on me that every time I have these talks, I bring up a new story, right? It's like I've not yet used the same story twice. Every single time I have a talk, it's a new story, because it happens that often. And usually it's a story, luckily for now, I don't have a new story because I've been off for the last 2 weeks. But it's because as a practicing physician, I see and hear these stories on a daily basis almost. And I think one of the things about doctors, and I know Dr. Birnbaum and Dr. Honigman, you guys can agree with me or not, I think after a certain point in time, you begin to normalize it. It's become something where these things occur, and instead of getting upset or sad or depressed about it, you end up having to normalize it for your own sanity's sake. And then you also have to try to figure out ways to navigate this complex system in order to make things work for your patients. And that usually doesn't mean that you end up giving the patient the optimal care. It ends up being that you kind of figure out a roundabout way of doing things and piecemeal things together and MacGyver things together to make it work. And so I think that that's what often happens with physicians. And that's how I feel about it now. But Dr. Birnbaum, Dr. Honigman, what do you guys think?
Go ahead, Bill.
I'll be real quick. So, because I know we're at the top of the hour almost, and let you wrap up. So more often, Maureen, I would see people who had troubles with the system, and so they ended up in the court of last resort, which was emergency. So, so they had already had those problems by the time they were seeing me. And but I would also see people who I would offer a treatment to, and they would say, "Well, I can't afford that," and they would just leave. And and that would be somebody with a belly pain or a chest pain, or that could be a life or death problem, or say a blood clot in the leg, and they wouldn't even get to see the doctor. We've heard of those horror stories too. So I think that one of those stories stays with you perhaps your entire career. It doesn't take a whole lot of them before you feel incredibly frustrated, and it ought to change the minds for a lot of doctors who are holdouts in this discussion. Ron?
There are a lot of ways I could answer that question, and it would some would take a really long time, and but what I would maybe I'll say this, which is that it's not just sometimes, it's constantly. it's like it, and actually when you peel away like a lot of things we've normalized, it's almost every interaction, every patient at some level. And in fact, because I'm not very good at normalizing it, that is the birth of the activist in me on this. In other words, like that's why this is happening every weekend, among other things, because it like I can try, but I can try to not be an activist about it, but it's like somebody with pitch that is off or something like that they're hearing like it. So our system is, for fairness and things that make sense, is the equivalent fingers dragged across like a chalkboard if you care about fairness and things actually just people getting taken care of, and it's nonstop. And so that is one of the reasons why we're here and why we're going to be, well, we're going to be back next week and keep working at this.
Thank you. I just like everyone to look at James Sarantino's comment. Normalization is a response to trauma.
Thank you. And I just want to go really quick to Betty. I know we're right at 7, but I saw your hand up and it's been up for a minute. So I just wanted to go and we can close it out with Betty.
Okay, well, I'm lowering it, so I didn't have a question. But yes, James, I do think that, and when we talked about the unhoused in this country before, and how what is it? Did mental illness lead to the unhoused situation, or unhoused situation lead to the mental illness? Because I believe once you get into such a state where you're unhoused, being out on the streets and having to live that way affects your mental health. And that normalization, unfortunately, and I don't want to bash Nomadland, but that movie irked me because I felt like it almost gave in to that normalization. People became homeless because of our Great Recession, losing their homes, losing their apartments, and then they went out, felt like, okay, we can't be in this rat race anymore, gonna go out and live in a van, and they normalized it, and they become normalized by it. But it's not really normal to just live that life or be forced into that lifestyle. And mental illness is huge, and we need care. We need care.
Yes. So I just wanted to kind of close this out on this topic in AB 1400. Between the doctors and nurses, never have I seen more doctors and nurses looking for another career. I know doctors who are seeking other careers, and I know nurses, including myself, who would be interested in another career, not because we don't care and not because we're not good at our jobs, but because we cannot deal with the ethical stress anymore. And I wasn't kidding when I said I want to go take care of red pandas at the zoo. Because I feel like I would just be happier with that. And that's sad. And like I said, it has nothing to do with the care of patients. It has nothing to do with the stress of caring for very sick patients. It has everything to do with the stress of being prosecuted by our employers because we did not bill properly, being prosecuted by our employers because I stayed on the clock too long to document something, that a sentinel event or something that happened, that either I documented, I'm in trouble. If I don't document it, I'm in trouble. So these are the things, the stresses that the healthcare system is putting on people, who is driving away good providers from our system. And something like AB 1400 may take that away because, they will not be so focused on, getting reimbursed and having to provide that pinch on the doctors for billing every single code. And so I just wanted to close out with that and just, keep it really, really real. And so I want to thank everyone for attending this CalCare office hours. I'm happy to be back, and thank you guys for riding this out with us. And we're going to continue to do this. And I do know elected officials who are seeing this, and because it has been brought up in other forums where they have actually mentioned office hours. So I know that maybe they're not joining our Zoom, but they are seeing this. And I thank you guys for coming in and seeing this. And I do encourage you to come into the Zoom room if you really have questions, or to reach out to us individually, because everyone that is here, myself, Dr. Birnbaum, Dr. Honigman, Dr. Nguyen, and anybody else that you see's names here, is it just diehard activists, you know we want to pass this, and we're offering our assistance and our knowledge to you because you are on that floor and you will be casting that vote. So I am sending subliminals and also very direct messaging to our elected officials saying, holla at your girl, I need AB 1400 passed. Any closing remarks from Ron or anybody?
Mine is, yeah, die hard, but we want to die a little easier. Okay, that's why we're doing this. We're dying hard now, so we can die a little easier later when it matters.
I want to put in a big pitch for next week's one, where we will have a special guest, Ryan Skolnick, and a regular, very special host, Jeanna Harris. Ryan, who is a super knowledgeable about AB 1400 single payers, an organizer for the CNA, and so an insider, and but just knows all this stuff inside and out. He's going to have new good things, to angles and all kinds of stuff. So I really just like encourage everybody to tune in.
Send more invitations out.
Yep, next week at 5. Have a good week, everybody. A non-morally injurious week in whatever you do.
Thank you, guys.
Bye.
Bye-bye.
Thank you. Thanks for looking at that, Paul.
Thank you.
Yeah, thank you, Bill.